Okay, Assalamu alaikum everyone. Sorry for the confusion. I think with Juma prayer, people were just trying to find this room and this session. So we are going to begin the free paper session this afternoon. It's 2:07. It's my great privilege to introduce the panel here today. Dr. Najma Shaheen, she is a pediatric oncologist at Shaukat Khanum Cancer Hospital, Lahore. Professor Abbas Khoker is head of oncology and radiotherapy at King Edward Medical University. Dr. Maria Kutbia is head of medical oncology at Shaukat Khanum Cancer Hospital, Peshawar. Thank you all for taking the time to be a part of this free paper session. So we will begin with the first free paper presentation, and I'd like to invite Dr. Maruf Khan, who is presenting on diagnostic validity of PIC-A, PIVCA-2A, and AFP levels for hepatocellular carcinoma. Thank you, Dr. Maruf. You will have 10 minutes.
Do you know hepatocellular carcinoma is the leading cause of the cancer-related death in Asia, noticing that 70% of the burden is tolerated by Asia. And due to the advanced imaging, we still lack the potential biomarker for early detection of carcinoma. Assalamu alaikum. Good afternoon. I'm Dr. Maruf Khan, and today we'll be discussing on the diagnostic validity of the PIVCA2 and AFP levels for hepatocellular carcinoma using CT triphasic as the gold standard. So, what are the main objectives today? It is to determine the diagnostic validity, keeping in view the sensitivity, specificity, positive predictive value, and negative predictive value of the PIVCA2 AFP and AFP, and to compare the diagnostic performance of both markers using CT triphasic as the gold standard and to evaluate the potential benefit of combining both markers. So before moving forward, I would like to review and revise some differences between AFP and PIVCA2 to make it easy for us to understand what is AFP. AFP is the alpha fetoprotein, that is a fetal protein re-expressed by malignant hepatocytes, and PIVCA2, it is the abnormal prothrombin that is produced by the malignant hepatocytes. AFP do reflect tumor, but also rises in chronic hepatitis and cirrhosis. Whereas PIVCA2, it increases specifically due to the effective vitamin K metabolism in the hepatocellular carcinoma. So to mention the sensitivity and specificity, keeping in view the recent researches conducted in the various countries like Korea, Nigeria, the AFP has a moderate sensitivity. It misses the small or early tumors with specificity of a lower rate with a high value of the false positives. And also, it is a traditional marker that has been used since ages. Whereas the PIVCA2 has a higher sensitivity, higher specificity, and is rarely elevated in non-malignant conditions. And it is an emerging complementary marker, which will be proved in my research. So, what is the study design? It is a case controlled study conducted in the Doctors Hospital and Medical Center located in Lahore from around January 2023 to June 2024. There were total 108 patients aged 18 and above, and this was divided into a case group and a control group. The case group had hepatocellular carcinoma patients, which were staged by using CLIP method, and control had the chronic liver disease patients without the diagnosis of hepatocellular carcinoma. So for the data collection, the blood samples were taken from the patients for PIVCA2 and AFP levels, and it was taken with the patient consent, and we used the CT triphasic as a gold standard. Please note that the few patients were not it wasn't affordable for them to do CT triphasic, so they are not included in this study. So the cutoff value for AFP is greater than 8.99 nanogram per milliliter, and for the PIVCA2 is greater than 148 mAh per milliliter. These blood samples were sent to the laboratory of the doctor's hospital medical centers. So for the data collection over here, we can see that the patients diagnosed with hepatocellular carcinoma are have a majority of male being 74.1%, and with the green indication and the red indicates the female with 25.9%. And here the female with in the patients which without the diagnosis of hepatocellular carcinoma, the male has 68.5% and the females are 31.5%. So here we have the descriptive statistics, which tells us about the case group and the control group with a mean value of 59.167, and the control group had the mean value of 59.889. And the next table, table 2, has descriptive statistics of the AFP and PIFCA2, where the mean value of PIFCA2 was 2124, whereas the AFP was just 391. So what were the results for that research? The results were the mean. Here we can see it in this graph, that the red line above is the PIFCA2, which has a rising trend and has a sensitivity of 70.4%, specificity of 76.8%, with positive predictive value of 98.1%. Then we have a green line which indicates the combined potential benefits of AFP and PIFCA2. And then in the end, we have the blue line indicating AFP with a sensitivity of 88.9, specificity of 75.9, and a positive predictive value of just 78.7%. So here it is, all the data has been in a tabular form just to make it easy to understand, and so that we can have a clear picture of what the research says. Here is a comparison between the sensitivity and specificity values of AFP and PIFCA2, where you can see the clear rise trend of PIFCA2, showing that is a potential biomarker for the diagnosis of hepatocellular carcinoma. In this slide, there are numerous studies that I've mentioned earlier also that have been conducted in Korea, Nigeria, and Pakistan, including my own study that showed that AFP and PIFCA2 together can improve accuracy, and also it highlights the superior diagnostic marker with a higher sensitivity and specificity, that it is the PIFCA2, word PIFCA2. So for the future research, I think there is a need on PIFCA2's role to be more descriptively defined in the hepatocellular carcinoma prognosis and survival. In the end, I would like to conclude the PIFCA2 being the superior biomarker compared to the AFP for hepatocellular diagnosis, and the studies and the descriptive statistics have explained it well, that the combined use can also improve sensitivity and specificity. So I would like to recommend that we should integrate PIFCA2 testing in the hepatocellular carcinoma surveillance program, because just a personal experience in my institute, many of doctors were unaware of the PIFCA2, what is PIFCA2 and what is the test being conducted. So therefore, I would really like in future to work on this research on a larger sample with multicentric validation. Here are the references that I have taken for this research. And thank you so much to all of you for showing such patience. And thank you so much for the team for making me the part of this and giving me this opportunity. I would really appreciate if any of you have any questions regarding this research.
Anybody has got any questions?
You're free to ask.
I have got a question. So, how do you compare the cost effectiveness of this test in a country which has got resource constraints? Patients cannot afford many of the tests. So, how do you place that?
Okay, so it's a basically blood sample taken from the patient, and it nearly costed around 800 rupees. So the cost was done because Doctor Hospital is a private institution, and mostly the patients come with which can afford it very easily. So to mention that PIFCA2 wasn't the main issue, a financial burden on the patient, but CT triphasic was. So I did not include the patients that had the limitation for CT triphasic, and that's why we only included the patients where there was no affordability issues. And it's just that we adjust the patients with, and some of the patients were given a little bit benefit because just to make my research work, that's why I had to give them a benefit. And just to mention, there were some patients who already had brought the PIFCA to report from some other institutions where they were tested.
Right, thank you. So in your study, male patients were predominant. Was there any specific reason?
I would like to say that it was just, you can say, unintentional thing that wasn't in my notice. But I was also intrigued by the question that why are males being more dominant in the patients diagnosed with hepatocellular carcinoma, along with the patients not diagnosed with hepatocellular carcinoma. But then, just for my own personal experience and personal clarification, I did a little bit of research on that. It's not part of my own research, but then I studied that males being prone to more stress, they are more prone to I don't want to offend anybody over here, but some of the male, I would like to say a minority, they are prone to drinking, smoking, and there are many risk factors that are brought to this that would highlight the chronic liver disease, cirrhosis, and so fatty, non-fatty liver disease. It's also a part of the cirrhosis. So therefore, these things contribute more in men than women.
So we are honored that Prof. Rob Steen is here with us, and he will be asking a question. So.
It's working. Thank you. I think that was a very interesting presentation.
Thank you so much.
You showed us the ROC curves. So were you able to confirm from the ROC curves that you had used roughly the optimal cutoffs for both AFP and
PIFCA.
Yeah.
Okay. So for the part of question I've understood, I would like to explain that for. Okay. Can we go back to the curve? That keeping in mind sensitivity and specificity values, okay, that have been mentioned in the graph, I need that ROC curve because the main objective of my research was that PIFCA2 is an emerging biomarker and it is more beneficial for the early detection of the hepatocellular carcinoma. And as I have shown in the graph over here, that the values of the PIFCA2, despite sensitivity is less, but the specificity is 76.8, and positive predictive value plays a major role in this because here we can see it's 98 and it's just for AFP just 78. So that was a major role that played to make that ROC curve being PIFCA2 the superior of all.
But the ROC curve allows you to estimate an optimal cutoff for positive or negative using, for instance, the Uden analysis. Did you try that?
No, I didn't try that, but for the specifically ROC curve, but I did try the cutoff value when we were doing the lab test that I've mentioned. For the AFP, it was 8.99, and for PIFCA, it was 148 mAh per milliliter. But for if we say the ROC, the cutoff value, I kept it a neutral so that it can be easy to understand because I was given only 8 minutes to explain my research in the most possible way and the most easy way for everyone to understand. But I would like to mention the cutoff in my extensive research that I have already had done. So I did mention a little bit into that. So if you would like, I can explain you with the help of my own research. Personally, I would really like to explain that to you.
Thank you.
Thank you so much.
Thank you.
Thank you.
We can take the next presenter.
Thank you so much.
Can you check, please, Dr. Iman Fatma, if she's online?
Yeah, we are going to first start with Dr. Amir. Dr. Amir Ahmed from the University of Alabama at Birmingham has joined us, and he will be presenting on precision medicine-driven pharmacogenetics, evidence-based stratification for improved outcome in non-small cell lung cancer.
Yeah. You can hear me? Yeah, good, good, good. So I have about 8 minutes to talk about a project that has been ongoing in for last 12 years. So I've been cutting short this talk for a long time. But yes, I am associated. I have been with the University of Alabama, Birmingham for a little time. But although recently I also moved to Qatar, so I'm based in Qatar right now. But I still hold this appointment with Birmingham. So, a couple of disclaimers. I started this project when I was co-owner of Oxford Biomedical Research in Michigan, USA. I still work for another company, Cancer Therapeutics Epigenetics Research, also in Detroit. So we started this very big project, and I will be maybe presenting only less than 1% of all this because I only have 8 minutes. So we started at University of Michigan, where I was for about 10 years before I moved to University of Alabama, Birmingham. Uh, so before I dive into some data or background, let me talk about a couple of keywords here: precision medicine, pharmacogenetics, and of course, then I will talk about lung cancer. That's my focus. I work on a couple of different cancers: lung cancer, pancreatic cancer, breast, but I'll probably try to make case of why lung cancer in this case. So when we talk about precision medicine, keep in mind, when you have people with a single disease, we often treat them as a single cohort. But all these colors are just to depict that patients with a single disease are still patients with very different genetic backgrounds. And we cannot give them all a single drug because some might respond, benefit, some might not benefit, some might even have adverse effects. So we cannot treat all of them similarly. We have to segregate them, we have to stratify them into groups based on their makeups and give them the right medication so that they get the best benefit. Pharmacogenetics is where we try to understand the genetic makeup. In my case, I try to understand the epigenetic makeup so that we can put a patient on a drug that they are most likely to respond to. So before you start the treatment, you should know which drug would work for them. That's the whole hypothesis. If you will get one thing from this talk. So I work on epigenetics. We work on DNA methylation, histone modifications. Of course, I don't have time to dwell into all this, but I will, and I have data on all of these, but I'll just talk a little bit about non-coding RNAs. Maybe you've heard about them, microRNAs, long non-coding RNAs. So for this presentation, I thought of lung cancer because of, before that actually, lung cancer, broadly two types. The most predominant one is the non-small cell lung cancer, NSCLC, which is 85 to 90% of all lung cancer. So when I'm talking about lung cancer, I am talking about NSCLC today. So why lung cancer? Because if you look at the statistics, this is published by American Cancer Society every year. This is the most updated data. And you can see lung cancer is number 2 in males and females in terms of incidence. But when it comes to deaths, it's number 1. And that's globally also number 1 causes of death worldwide. Almost 1 out of 4 all cancer deaths are because of lung cancer, and lung cancer kills more people than colon, breast, prostate combined. Now I have specified colon, breast, prostate because these are number 2, 3, 4 cancers. So number 1 cancer, lung cancer, kills more than 2, 3, 4 combined. So it kills a lots and lots of people. So why did we talk about precision medicine? Because if you were a physician, you have so many choices. A patient comes in, you have so many choices. These are all FDA approved drugs as of September. So what do? Of course, you can order some tests, and we do have some targeted drugs for lung cancer patients based on some KRAS mutations, ALK rearrangements, and EGFR mutations. And this is what I will talk about today, EGFR mutations. But yes, you do have a choice. You can do some tests. And again, even if you figure out that the patient has ALK rearrangements, you have 5 different drugs which you can put your patient on. The major thing, take home message would be that even if you put on one of these medications, patient might not respond. And then after 6 weeks, 8 weeks, you put them on a different drug, you have lost those 6, 8 weeks, which is very, very crucial. And that's why, and if there was no genetic mutation that could figure out, you would put them on some non-targeted drug, one of these 40 months. So you are losing time. And EGFR mutations, EGFR is a tyrosine kinase, and what we have is when we figure out that there is EGFR higher expression, EGFR TKI, tyrosine kinase inhibitors, were approved in early 2000s. These were the first generation EGFR TKI, and then we realized that soon patients develop resistance, and then EGFR TKI, second generation, came into existence. But then I started working when we saw that a particular mutation, EGFR T790M, would start resistance against this second generation medication. So I was working on I started working on EGFR TKI, the third generation. I was involved in the clinical trial and FDA approval of this. So we worked specifically on osimertinib, which was approved by about 10 years back, 9 years back. And even when we got it approved, we already started working on a fourth generation, which is not yet approved, because we know that eventually patients will develop resistance against this drug. So what are the questions we have? Of course, the biggest question is where to start? What first drug should we try? Now, you might say, why not we start directly with the most advanced drug, third generation? But no, what we have seen is some people do not respond to third generation. They respond better to first generation. And also third generation works only when you have already acquired the mutation. So it's not about first, second, third, which not the best, but we have to somehow figure out that which drug would be the best. But we also realized what probably EGFR mutations are not the best things, and that's why we moved beyond genes. We moved to non-coding RNAs, and what we did, this is the design. We started with a retrospective arm. We looked at retrospectively into the data of patients, and then we did a validation arm. For retrospectively, we had this third generation and a new fourth generation drug. We thought that we will have at least 150 patients for each drug. What we ended up was we looked at the microRNA, which stops transcription, just to give you an idea. So we ended up with 542 patients data, 331 on osimertinib, 111 on the fourth generation drug. And again, I know I have to script to this, but we found a microRNA signature that could predict response to third generation or the fourth generation. So basically, we can order a blood test for patients, and we can look at these microRNAs, and based on this expression, we can direct patients to either third generation or the fourth generation. So let me skip through this. So what we observed was, normally, when you put patients on this third generation drug, only 47% patients respond. Of course, the ones that have this mutation, they respond a little better. Those that do not have mutation respond very poorly. Again, why do they even 12% respond? We do not know. But if we direct them based on our epigenetic signature, now suddenly we see a 77% response. So we believe that epigenetic signature is way better. So in terms of overall survival, progression-free survival, we have already seen an increase from 34, 16 months to over 52 months. As of last month, patients are doing good. And on the fourth generation drug, from 17.8 or progression-free survival.
Presentation time is over.
Okay.
2 minutes are for the question.
Okay, no problem. So I think I just made a case that based on our epigenetic signature, we can stratify patients and try to put them on a drug on which they would respond the best. So I'll write.
Thank you so much. Thank you so much, Dr. Amir. It was a wonderful presentation and wonderful study. I would like to have one question only.
Yes.
You have shown that osimertinib was not that effective in those patients who were not having T79M mutation. But in fact, it is recommended in all those patients, either they are having T790 mutation or not.
That is not the best strategy, because the whole FDA approval of osimertinib was based on the acquisition of this mutation. So it's only prescribed for people, but in many cases, we as physicians are so desperate. So whenever patients fail on first or second generation, they are put on third generation just because that's the most advanced. But osimertinib actually works only with T790M positive mutations. Patients.
So that's something which is new for me, actually.
Yeah.
So anyone in the audience have any question?
Yes.
Assalamu alaikum.
Yes.
Apart from drug resistance, you told that when a patient is resistant to one, you move to other. Is there any cross drug reactivity that a patient is already taking one? So, to avoid that cross drug reactivity, you move to the other generation, or is there any specific side effect that in few patients you have to avoid that? That's why you move to another generation.
We do not see side effects, but we do see that when patients are treated with, for example, in this case, first or second generation of TKI, only then they get enriched for the T790M mutation. We do not know why that mutation happens. Maybe it's because when patients are exposed to first, second generation, that kind of cancer cells, the T790M plus, get enriched. So that could be a side effect. So sometimes, yeah, but then that's how they will start responding to third generation.
So far, have it shown any cross-drug reactivity with any of the drugs? Like for
No, not at all. No.
okay, thank you
Thank
so
you very
much.
much.
Yeah.
We can take the next presenter now.
Thank you.
Thank you.
Right. So the next presenter is Dr. Saida Tehreem Zara, who will be presenting on outcomes of relapsed refractory extracranial germ cell tumors. Yeah. There you go.
Assalamu alaikum. Good afternoon, everyone. Thank you, Dr. Alina, for inviting me. So today I'm presenting a survival outcomes with conventional salvage chemotherapy for relapsed or refractory extracranial germ cell tumors. I have no financial disclosure or any conflict of interests. So briefly, germ cell tumors represent a rare and heterogeneous group of neoplasms that approximately 3.5% of the pediatric population have these malignancies. The incidence of extracranial GCTs varies geographically, but the annual incidence is estimated to be around 0.5 cases per 100,000, including children and adolescents. Approximately 20 to 30% of the patients with advanced GCT will either not achieve remission or subsequently relapse following first-line therapy. For these patients, salvage chemotherapy regimens remain the mainstay of treatment. Reported response rates to first-line salvage chemotherapy range between 20 to 50%, depending on tumor location, prior therapy, and risk stratifications. When I was looking for the data from Pakistan and from our regional countries, there is a paucity of data related to the conventional salvage chemotherapy for relapse or refractory germ cell tumors, so which led us to conduct this study at our institute. So the main objectives for this study was to understand the outcomes, response rates, prognostic factors, and optimizing the treatment protocols and resource allocation in LMICs especially. The present study evaluates remission rates and survival outcomes of pediatric relapse and refractory GCTs managed with conventional salvage chemotherapy regimens. This was a retrospective review which was conducted at Shaukat Khanum Memorial Cancer Hospital during the period of January 2011 to December 2022. So total patients which were seen were 283 patients. Out of them, 41 patients were relapsed cases and 10 patients were refractory cases. So a total analyzable cohort was of 51 patients. At initial presentations, we stratified the patients according to their risk groups, according to CCLG guidelines. The completely resected teratomas and stage 1 gonadal tumors were classified as low risk with any level of AFP. However, stage 4 ovarian and stage 3 and 4 extragonadal germ cell tumors or AFP of more than 10,000 were taken as high risk groups. And all other cases were stratified as intermediate risk according to CCLG guidelines. The Kaplan-Meier method was used to estimate the event-free survival and overall survival with comparisons between groups performing using the log rank test, and statistical significance was set as a p-value of less than 0.05. So, relapse was defined as the reappearance of disease after initial response and then serially increasing tumor markers or clinical radiological progression, either alone or in combination. And refractory GCT was defined as progression occurring during primary treatment or within 4 weeks of completion of therapy, as evidenced by biochemical, clinical, or radiological criteria. So, here we can see that amongst these 51 patients, 33 were gonadal relapses and 18 were extragonadal relapses. And amongst these patients, initially 45.5% patients were in low risk categories with gonadal GCTs, and 66.7% were high risk at initial presentation, including the extragonadal GCTs. So both these groups received the JAB chemotherapy as first-line treatment when they were initially treated and followed by observation. And most common histology for these both groups was yolk sac tumor, followed by mixed germ cell tumor histology. The most common salvage chemotherapy regimen used at our center was VEIP or VEIC in 54.9% patients, and 31.4% patients were treated with surgery alone at primary presentation that do not had any carboplatin or platinum-based chemotherapy at baseline, received BEP or JAB at relapse. And we used other second salvage chemotherapy as a third line in some cases, including TAPE or TIC, which was used in 5.9% of cases of extragonadal GCTs. And IPO was used in one case as a salvage chemotherapy in extragonadal GCT. Surgery was performed at relapse or post first salvage chemotherapy for local control where indicated. So I have summarized the results in a broader way for gonadal and extragonadal DCTs. We can see that in gonadal group, there is 66.66% alive without disease patients. So there was a very good overall survival for these patients. However, the extragonadal relapse CCT do bad. Only 22.2% of the patients were alive without disease at the end of the study. And mortality was more common in extragonadal GCTs at relapse. The mean duration of follow-up was 90.9 months, and the overall survival at 3 and 5 years was 78.4% and 72.5% respectively. The event-free survival at 3 and 5 years was 60.8 and 50% respectively. So it was a good overall survival and event-free survival comparable to the data internationally. So as we can see that in the gonadal tumors, including the testicular germ cell tumors in relapsed cases, have good overall survival in comparison to ovarian or extragonadal germ cell tumors at relapse. Similarly, event-free survival was better for extragonadal diseases. However, the gonadal diseases had a less event-free survival because these were the patients who were kept on observation initially, and that was more likely to be expected. So we did a multivariant analysis. We saw that compared to low risk group, patients in high risk group had a significantly higher hazard of death, like a hazard ratio of 12.27, which was significantly high for a high risk group. And intermediate risk group also had an increased hazard compared to low risk, but this was not statistically significant. As we can see, the hazard ratio for high risk patients is 12.27. So high risk disease was independently contributing to the mortality. So in conclusion, we conclude that salvage chemotherapy regimens provide effective option for children with relapsed or refractory extracranial GCTs. Long-term survival is achievable, especially in patients with gonadal primaries and low-risk features. High-risk and extragonadal disease remain associated with poor outcomes, highlighting the urgent need for new therapeutic strategies, improved supportive care, and integration of novel treatment modalities. These are some references which I referred to. And thank you. Any questions, please?
Thank you very much, Doctor. I have two questions.
Sure.
One that you have included the cases of mature teratoma in your study.
Yes, we did.
So generally they are considered benign. and the therapy for them, whether they are recurrent or in the primary setting, that is only surgery.
जी
Um, so, how would you like to comment on this? Why would you include mature teratoma in your study?
No, I just mentioned that we performed surgery at relapse wherever indicated. And when first salvage chemotherapy was indicated, those cases were excluded. The surgical cases were excluded from these first line salvage chemotherapy outcomes.
Right. And secondly, in the Kaplan-Meier graphs, you have shown that there were extragonadal tumors, and then you segregated all the gonadal tumors into ovarian and testicular and otherwise. Why haven't you clumped them into one group, gonadal versus extragonadal?
Yes, I should have. I do have those graphs in my parent research, but I have not included in this presentation.
Right. Any question from the audience, please?
Thank you.
All right. Thank you, Dr. Tahreem. So just so everyone's aware, Dr. Najma will not be scoring you because she's part of the study, but I will be scoring you. Okay. So we have one person who's joined us online. Is there anyone in this room who's here to present and hasn't already? Oh, wow. Okay. All right. So आपका नाम? Mariam? Okay. And then we can have, okay. So I'll invite Dr. Mariam OS to present on the silent invader, elucidating the role of HPV in PDAC versus in silico integrative multiomics analysis. Mariam Asad or OS? Okay. So the presenters who've joined online, they may, sorry, have to wait till the end. एक सेकेंड ये है चल रहा है ये ठीक wait.
Assalamu alaikum everyone. My name is Mariam Awais and I'm a second year medical student at Dow Medical College, Karachi. The topic of my presentation today is investigating how hepatitis B virus can cause primary pancreatic ductal adenocarcinoma. So, pancreatic ductal adenocarcinoma or PDAC is actually one of the most lethal malignancies that one could have. The rate of mortality actually mirrors that of incidence, and in Pakistan, 97.8% of all pancreatic cancers lead to mortality. Unfortunately, PDAC is usually diagnosed in its later stages when surgical resection is not an option. And PDAC inherently, it's very treatment refractory to most of the chemotherapies available out there. Now, Pakistan also happens to be one of the one of the nations with the highest chronic HBV burdens. HBV, even though it has an effective vaccine that is recommended by WHO, we unfortunately do not afford the luxury of herd immunity. Now, why am I studying both of these two together? It's because my epidemiology data says so. There have been multiple case control, observational, and cohort studies that have recorded significantly elevated risks of developing pancreatic cancers in patients with a history of chronic hepatitis B or a history of even an acute hepatitis B infection. Now, a thorough literature search led me to understand that hepatitis B has been thoroughly researched in HCC, hepatocellular carcinoma. But even though there is a lot of epidemiological data available, there isn't any molecular level study available. The question is, we all know that hepatitis B is a hepatotropic virus, right? The liver has these sodium taurocholate co-transporter polypeptides that allow HBV to infect the liver and chronically stay in it. Then what is hepatotropic virus even doing in the pancreas? And can it infect the pancreas? The answer is yes. There's multiple routes, maybe the biliary, the hematogenous, and even molecular entry mechanisms. Now, this is my methodology. I've used multiple different bioinformatic and data analysis tools that I will make you guys understand and walk you through my entire methodology because it has a couple of steps. First, I wanted to look at what the fundamental difference between a hepatitis B positive and a hepatitis B negative PDAC patient is on a transcriptomic level. However, because the virulent status of most patients that present with PDAC is not recorded, I couldn't find any relevant data for me to analyze. So I took a step back and I wanted to understand what we already knew about hepatitis B. How does hepatitis B talk to our body? There's two ways. A, it takes a seat. What do I mean by that? It takes a seat as in hepatitis B integrates its genome into the liver genome. Secondly, it has a little bit of a chat. What do I mean by that? The viral proteins in hepatitis B actually interact with the human proteins that then leads to infection. So I try to listen into these conversations. First, this right here is a human HBV protein interaction network that I have made using curated databases such as Intact and String, which have already recorded such molecular interactions for me. This essentially shows me which viral proteins are interacting with which human proteins in the body that is then leading to infection. Now, my next step here is I wanted to see what unusual conversations are happening in PDAC. So for this, I ran a differential gene analysis on different cohorts that I got from TCGA, GEO, and I then keeping my p-value less than 0.05 and my log fool to change more than 2, which essentially means give 4 times the expression. I have my down and up regulated genes over here in different cohorts. Now I wanted to see, is there anything common between the two? Yes, there is. And interestingly enough, the most significant intersection is in between these two cohorts. This GC numbers means the geo cohort, right? Now, why is this interesting? Because these cohorts are Chinese. And why is that interesting? It's because China also happens to be an HBV endemic nation, just like Pakistan. Now, the next thing I said was that HBV takes a seat in the body, right? It integrates in the genome. But where in the human genome does it integrate? For that, I used the VIMIC database. And I found all of the integration sites in the human genome where HBV goes and integrates itself. Then I found the common genes between the PDAC dysregulation over here, these, and then my integration sites. And I found 267 common genes. An interesting thing that I want all of you to notice is that this year, in July 2025, the first ever study that has reported HBV integration in pancreatic tissue came out in. It's a Chinese study that used mouse models and pancreatic cancer cell lines. Hasn't been validated in humans, but it's a step in the right direction. And it's the first study of its kind. Now, I have these multiple intersections. All I had to do was look for the common point. I did that and I found these 4 common genes. These are my 4 common genes that could give us a molecular insight into how HPV could cause oncogenic progression in PDAC, right? Now, these are my 4 genes. Interestingly enough, these 3 genes are actually tumor suppressors, and all 3 were down-regulated. And this FLNB, which is my filament B protein, was upregulated. And this protein is actually responsible for metastasis and tumor progression. All these 4 genes have been very thoroughly studied in other cancers. For example, over here, this FLNB is responsible for mesenchymal transition in breast cancer, so breast cancer metastasis. These other proteins, this has been studied very well in HCC, which is hepatocellular carcinoma. XBP1 actually has an ongoing trial in ovarian cancer, in which the mitigation of dysregulation of XBP coupled with chemotherapy is yielding positive results in ovarian cancer. All of these, however, are not properly studied in PDAC. What did I do next? I wanted to look at where these 4 genes are the most enriched. Now, I used enricher, and I found where this was significantly acting. So I found a few significant results. I saw that P53 pathway was elevated, essentially meaning that these 4 genes were involved through the P53 pathway in causing cancer. Similarly, I got JAK-STAT signaling pathway, I got cerebral ataxia. All of these, again, are molecular insights into how the dysregulation of these genes, because of HPV infection in the body, could be causing PDAC. Now, my study has a lot of limitations. First of all, there isn't any functional validation, and I've used a lot of databases which inherently come with bias, like batch size, a different batch. They're from different cohorts. As I said, that I got the most overlap in these 2 cohorts as compared to these, because these 2 were Chinese cohorts, and like Pakistan, China is HBV endemic. Now, what's my way forward? My way forward would be to validate my findings in patient-driven data. Now, we know that Pakistan does not have a cancer registry, and we don't have any sequential data. But if possible, we can isolate these genes, the expression, it's possible has been done in other cancers, and run an RT-PCR in my patients and see if the expression is upregulated or downregulated, or however it is dysregulated in HBV negative and HBV positive PDAC samples. And if our results yield if our study yields any significant results, that's a step in understanding the molecular basis of how HBV is driving oncogenesis in PDAC. These are some of the references that I've used. To access the abstract, you guys can scan the QR code. Thank you. The floor is open for questions. Thank you.
Thank you very much. It was a wonderful presentation, although most of it goes above my head. But I would like to appreciate the structure, the logic, the methodology that you used was amazing. And I would also like to know, who is your mentor?
The PI on this paper is Dr. Faisal Khan. He heads the precision medicine lab in Peshawar, Rahman Medical Institute.
So impressive work.
Thank
Any
you.
question from the audience?
This was a part of an elective that I did in Peshawar a few months ago.
Any questions? Yes, please.
So, great talk. What
Thank you.
comes next?
As I said in my way forward, these 4 genes that I've isolated or I've understood have been investigated in other types of cancers, but these haven't been properly understood in these haven't been understood in PDAC, and they haven't been understood with in context of how they interact with HPV. Over here, as I've mentioned, that I've also mentioned which viral protein these genes interact with and how they cause the dysregulation and how they cause these genes. Essentially, what do they show? They show in which viral proteins they interact with and then cause HBV infection. They also show that they were dysregulated in PDAC, which means they had significant results in causing oncogenesis in PDAC. And they show that actually that's all they show. But for now, we need to investigate them. Patient-driven data is very important. We need to be able to isolate them. We need to understand if their expression differs in my HBV positive and HBV negative individuals. Because if we understand, let's say we are able to isolate even one of these genes, we are able to maybe tap into the therapeutic and biomarker potential of these genes. And if there's a cost-effective way to tap into those areas, we can screen for high-risk individuals. Because as I said, PDAC is usually diagnosed in its later stages when surgical resection is not an option. And again, PDAC is very treatment refractory. It only has like gemcitabine for its as treatment option, and it's usually that's it. Thank you. Any other question?
Thank you, Dr. Mariam. So we will move on to the next presentation.
Yes, thank you. So you, just a reminder, you have 8 minutes for presenting and 2 minutes for questions. So we have Dr. Mohammed Ansab. Let me open his slides. Dr. Mohammed Ansab from Services Institute is presenting on thermal ablation compared to surgical resection in colorectal liver mets, a grade assessed systematic review, survival meta-analysis and meta-regression.
Uh, Good afternoon, everyone. I'm Mohammed Ansab, a fourth year medical student from SIMS Lahore, and I'm going to present my research, thermal ablation versus surgical resection for colorectal liver met, a great assessed systematic review, meta-analysis, and meta-aggregation. This was done under supervision of Dr. Anwar Said from University of Pittsburgh School of Medicine. So coming from the background, colorectal liver metastases occur in about 50% of the colorectal cancer patients. And historically, resection is the gold standard of treatment, and ablation is used mainly for those patients that are not candidate for a surgical resection. But ablation is a non-invasive technique, and it may be preferred by the patient. It is more preferred by patients that do not want to go through the surgery. So the data has, although resection is the gold standard, but data has always been conflicting, and eventually the recent collision trial has made this has increased the ambiguity of resection versus ablation. So our rationale was due to the conflicting evidence and the recent trial that was collision, we synthesized other studies that use resection, surgical sectional or ablation for colorectal liver mets, and our objectives was to compare survival data like overall survival and disease-free survival and recurrence patterns.
जी
Uh,
HP कर दें
so methodology, it adheres to Prisma 2020 guidelines and it was registered with Prospero. We said databases such as PubMed, Embase, and Web of Science. Inclusion and exclusion criteria, as I have already explained, was thermal ablation or resection for colorectal liver metastasis. And our outcomes of interest were OS, DFS, and local and distal recurrence. As dual review screening was done, extraction of demographics, tumor size, modality, and follow-up was done. And for risk of bias, we used drop2 and Newcastle Ottawa scale. And for grading, we used the grade framework. So, and statistical analysis was done under a random effects framework using a restricted estimated maximum likelihood method. Heterogeneity was calculated using I-scale and T-scale statistics, with interpretation with 25% being low, 20 to 5 being moderate, and more than 50 being high. And sensitivity analysis, aggregate regression, and test and control analysis for the plot R index, everything was done in this study. And meta regression was done to test moderators such as ablation, tumor size, and age. So this is our search results. 2259 records were identified, and after removal, replication removal, and screening, we have 29 studies with 5,719 patients. These are study characteristics. Basically, most data was in retrospective cohorts, but there were four prospective studies and one R study. That was the collision study. Median and baseline were comparable between these studies. So this is the synthesis of overall survival, and it may seem that it is built on the previously built notion that resection is superior to ablation, which is the hazard ratio was 1.56, that is 56% higher mortality risk for ablation cohorts as compared to resection, and it was significant. But the different, what I will explain how it, although it is considered like the gold standard, but it is conflicting, and I will explain how. So when we did subgroup analysis, so the main issue was ablation techniques evolved. So when microwave ablation was used, the risk difference, the survival difference was not significant. It was significant for radiofrequency ablation cohorts. Uh, Other significant thing was then we subgroup patient based on age, and for the younger population, there was survival benefit with hepatic resection, but for age greater than 65, there was no survival benefits. Then ablation and resection was have same survival benefit. Our other significant thing was we subgroup based on tumor size, and it was one of the rationale of collision trials that tumor size may have an impact on survival. So when liver metastasis was less than 3 centimeter, the ablation and resection have no survival difference. But for greater than 3 centimeter, resection was resection was better than ablation for overall survival. So these are our plots for meta regression that attenuates what I said previously for subgroup. As you can see, as the mean age increase, the survival benefits start to disappear. That is the hazard ratio approaches one, that is there is no difference between resection and ablation. And when tumor size increase, the ablation, the resection appears to be better than ablation for it. So for disease-free survival, again, the one of the main the hepatic ablation was the-
Thank you. Your time is over. We can take the question now.
I will appreciate if anyone has any question.
So I have a question. Did the number of the meds has any impact on the survival?
So basically, it was more based on the size of the meds. Like if they were small size, like number of med, like it was in the second slide.
You can tell us all verbally.
So there was no like the size of the tumor was main contributor. Like if it was small size region, then ablation and resection were comparative for no.
It was a very nice presentation. Thank you so much.
All right, thank you to Mr. Zishan, especially because he's a fourth year medical student. It's very nice to see someone participating in that way. Well done. So we have online two individuals. So we have Dr. Iraj Ikram. We're gonna have to share the Zoom.
Assalamu alaikum, everyone.
1410 second. ये पीछे गई है ये Viraj.
So Miss Iraj, you can go ahead and unmute and share your screen.
Um, Sorry, I cannot see the show screen option.
Can you hear us?
Yes, I can.
Sorry.
Hello.
Okay, Iraj, you're gonna have to unmute. Okay, it looks like you're unmuted. Can you type in the chat if you're having trouble with?
So the chat is disabled and I cannot
I
see
think
the
we will
screen option.
try to come back to you and move on to Dr. Mehwish Fatma. So, Dr. Mehwish, can you hear us? Can you try to unmute and let us know? And for the meanwhile, we'll mute Iraj.
Say something. Hello, Assalamualaikum.
Okay, looks like you are talking and we cannot
Can you hear
hear
me?
her.
I can't share my screen.
Keep talking, Dr. Mehwish.
Could you please allow me to share my screen?
Yes, we can hear you. Can you share your screen with us, please? Let us know if you do not see the share screen option.
And let them know you cannot. I can't share my screen. You cannot see. There is no option.
There's no option. Okay, we'll make you a panelist. We have to make her a co-host or a panelist so she can share her screen. Okay, try now, Dr. Mavish. Go ahead and try now
Yes.
to share your screen. It should be at the bottom of your screen.
Yes.
Perfect.
Can you see here?
I can see it. Please put in presenter view. So what we're going to do is give you 8 minutes to present and 2 minutes for questions. And please go ahead. You can start now.
Okay, so I'm Dr. Mavish. Here is a disclosure that I do not have any conflict of interest. So the topic is neuroblastoma. So neuroblastoma is a juvenile cancer and a leading cause of cancer in children. It is originated from the neural crust cells of sympathetic nervous system. When an immature nerve cells known as neuroblasts develop abnormalities and proliferate uncontrollably to create a tumor. It is originated in the nerve tissue of adrenal glands. The clinical presentation include lump in the abdomen, lump in chest, bone pain, bruising around the eyes. So, it is also associated with the MYCN and ALK mutations, whereas it can raise the HVA, that is homovinylic acid, in urine. And there is a prognosis that 67% of the children survive 5 years after a neuroblastoma diagnosis. Now, coming towards the disease burden, according to the American Cancer Society, it's about 600 to 800 new cases of neuroblastoma. Globally, incidence of neuroblastoma, according to the 2021 report, there is 5,560 cases with 1977 death occurs. Incidence rate increases from 1991 to 2021. You can see over here that it is increasing from 0.25 to 0.28, which shows which contribute the overall 12.1% increment, and the mortality rate is 20.35 percentage. At the national level, India has the highest number of neuroblastoma cases globally in 2021 with 685 cases. Now, coming towards the current methods of neuroblastoma therapy, which include surgery, chemotherapy, targeted therapy, radiation, and immunotherapy. Despite all these multimodal therapies, the treatment outcome remain suboptimal due to the chemo-resistant and systemic toxicity. So we decided to take this flavonoid, which is a rare flavonoid called as patulatin, with the known antioxidant and anti-inflammatory properties. And it gained attention for its potential anti-cancer activity. The C6 methoxy group, which is present with the A ring produces biological activity, and it is extracted from different species, different flowers of Inula japonica and Taggart's species. So we decided to investigate the anti-cancer effect of patulatin on neuroblastoma cell line SHSY5Y. Here is the method. These are the methods which are utilized for this research. Now, these are the results. So cell viability assay shows there is a drastic inhibition in proliferation and induces apoptosis at 48 hours. You can see in the images too, which shown there is an inhibition, or there is a multiple death in 100 micromolar dose. And there is a graph of Trypan blue and Trypan blue assay. Trypan blue assay shows, you can see in the graph that 50% of inhibitory concentration shows at 25.6 micromolar, which is further validated with CCK assay, which shows 23.68 micromolar, which is the inhibitory concentration. Now coming towards DNA fragmentation assay. So DNA fragmentation assay shows the time and dose dependent increment with the patulatin treatment, and it suggests that a significant apoptotic activity has been done. So we decided to see the effect through gene staining, either it's apoptotic way or not. So Jinja staining says that you can see in the images that 50% and 100 micromolar, there are apoptotic bodies and cell shrinkage, which is a hallmark of apoptosis. And it is a hallmark of apoptosis, and you can see there is a condensation of chromatin in the center of the cells. Now coming towards another one, that is the apoptosis assay. So apoptosis assay shows apoptosis assay has been done through flow cytometry, and flow cytometry you can see the different quadrants. So Q3 is a viable cells, and Q4 is the late apoptosis one, and Q2 is the late apoptosis one, and Q4 is the early apoptosis one. So you can see clearly that there is a rightward shift, that is most of the cells are present in Q4, that is the early apoptosis region. So the graph shows that it is drastically increases in early apoptosis. Now coming towards this one, that is the cell cycle assay. So cell cycle assay, when we have done the cell cycle assay, the graph shows that G naught, there is a increment in sub G naught phase, which is a hallmark of apoptosis, and it confirmed that there is an inhibition at sub G naught phase, and there is apoptosis over here. And you can see over here in the graph that there is also suppression in S phase. S phase, which shows that the synthesis of DNA is confined. So this pattern is also seen in the etoposide, which is the drug which is already used for neuroblastoma treatment. Now coming towards another one, which is the Ross determination assay. So we use NAC, that is N-acetylcysteine, which is an antioxidant one, and it reduce or suppress the ROS present in the cells. So in normal 25 micromolar, 50 micromolar, and 100 micromolar, there is an increment in the DNA fragmentation. But when we use the NAC with 25, 50, and 100 micromolar dose of patulatin, there is a hallmark increase of death. That means that NAC support the inhibitory action of patulatin, and increases and it increases the death rate. So you can see in the graph that the effect was seen in the NAC one is also increasing. So here are the conclusion ones, that our finding demonstrate that patulatin exert potent anti-proliferative effect through apoptosis induction, supported by experimental approaches. The exact molecular target of patulatin remain to be evaluated, and its strong cytotoxic effect against neuroblastoma cells, which is the highlight that might be this one is the plant-derived therapeutic candidate. And here are the graphical summary of all the experiment, which shows that. So this one is the graphical representation, and thank you so much.
Thank you. We can take the questions now.
Yeah, sure.
So I have a question, a very good study. Did you check for the sustained response?
Sorry, for the sustained response?
Yeah.
So this one is a preliminary one, and we are performing different experiment over here. So the methods are in our experimental looking. So we are doing it.
Okay, thank you. I have got another question or a comment you can say, because I think in Europe and West, people are talking about like developing molecules and then targeting various mutations. But I think your work is more like it is combining the herbal and the targeting the molecular mechanisms. So I think I would really appreciate your efforts and
Thank you.
further studies. Definitely further studies need to be done on that so that we can probably come up with some exciting new medications which are cheaply available. As of now, we all these targeted therapies, they are quite expensive. Thank you very much.
Thank you so much. Thank you.
So any other questions from the audience?
So thank you, Dr. Mevish. So you can mute yourself now. And what we'll do is we'll move on to the next online, the last, I think, session of this, the last presentation of the session. So Dr. Iraj, we're going to try to take you on again. We will try to make you a panelist. Okay. So Dr. Iraj, go ahead and try to unmute yourself. And can you hear us? I don't think your microphone is working, Dr. Iraj, because can you try to share screen? Okay, so it looks like your share screen function is working. Can you join on your phone so that in one place you'll be joined on the laptop and one place you can join on your phone so that we can hear you, because we cannot hear you right now.
Am I audible now?
Yes, yes, you are audible. Excellent. So we are going to start. Please put your slides in presentation mode. You have 8 minutes to present and 2 minutes for questions. Please go ahead.
Okay, thank you so much. Assalamu alaikum, everyone. I'm Iraj Ikram, a final year medical student from Khyber Girls Medical College, Peshawar. And my research is answering to a very critical clinical challenge that we face today. That is the targeting of BCG unresponsiveness in non-muscle invasive bladder cancer using the drug repurposing via transcriptomic profiling. So, in order to understand the urgency, we need to start with the scale of the problem. Bladder cancer is one of the most common malignancy of the urinary tract and 10th most prevalent cancer worldwide. It has two types, the muscle invasive and the non-muscle invasive type. The non-muscle invasive type is usually limited to the outer bladder lining, and it comprises of almost 75% of the total bladder cancer patients that are presenting here in Pakistan today. So, for high risk non muscle invasive bladder cancer, after the first initial 2-RBT, our primary approach is BCG. What is BCG? It's actually our TB vaccine that is given intravesically, and it it acts as an immune booster that will use the immune system of the patients to prevent the tumor recurrence and its progression. And today, it is one of the gold standard therapy used for the treatment of non-muscle invasive bladder cancer. So BCG is working, but does it work for everyone? Unfortunately, the answer is no. Almost 40% of the patients, they have relapse or recurrence after the 6-month disease-free interval, and 25% of the patient has to discontinue the therapy because of the intolerable side effects. And in these non-responsive patients, the standard therapy is radical cystectomy, the removal of bladder. It's our best shot at the long-term survivals, but it does come with its own drawbacks because it has high morbidity, mortality, and loss of quality of the life of the patient. So it makes the treatment uglier than that of the disease. So the question arises, ladies and gentlemen, that if BCG is no longer working and radical cystectomy is our last resort to treat these patients, can we change the story? And that is where my research steps in. The objective of my research were to repurpose the existing FDA-approved drugs as a potential alternative for the BCG unresponsive patients on the basis of the gene signature, and also to identify the cell surface protein targets that can serve as future drug targets. So together, these both will give us a foundation towards safer, more effective strategies rather than going for radical cystectomy. So let me walk you through our methodology. My research started with a systematic literature review on PubMed in order to find out the already potential repurposed drugs. After that, I compiled publicly available data sets from GeoDatabase. And I ran an extensive differential gene analysis using RStudio on these data sets, and I was able to identify significant gene signatures. And then I mapped these gene signatures on drug mapping tools like L2S2 and DrugSeq2. So let me start with my results. These are the 6 data sets that I utilized for my study. In conclusion, like in total, I had 294 samples of T1 high risk bladder cancer patients, and they had their BCG response status mentioned. So these are the pretty graphs that I got through the differential gene expression analysis, and they quite provide evidence to what we predicted in the earlier. On the left side, you can see a volcano plot that shows us the differentially expressed genes between the responders and non-responders. And for that, we have a p-adjusted value of less than 0.05, and the log to fold change was greater than 1. The upregulated genes are present in red and the downregulated in blue. On the right side, we have the PCA plot that shows that there's a significant separation between the BCG responders that are shown in the blue and the non-responders that are shown in the red. So what do we conclude? From here, the clear separation conclude that there is actually a significant gene, like a unique gene signature that is actually leading to the BCG failure. And that give us a further motivation to towards the finding out the drugs. Now, these Venn diagrams, I have compiled the upregulated and downregulated genes among all of the data sets to find out the common genes that are the molecular driver of the BCG failure. And then those DEGs, I mapped them on the drug mapping tools like DSeq2 and L2S2. And from there, I got the drug list. So among these drugs, edifinine, with its lowest p-adjusted value, gave us like a potential, have a potential to be used in the BCG unresponsive patients. It's an anticholinergic receptor inhibitor. So do I stop there, or I took a step further? Repurposed drug, they gave us like one option, and we asked this question that can we leverage the the cell's surface membrane proteins, and they can give us like a new potent drug targets for treating this BCG unresponsiveness. And for that, what I did was, previous studies have been done that in order to find out good immunotherapeutic targets, we usually compare the disease data with that of the normal data, and from there we can get a good immunotherapeutic targets. And I utilize the pipeline of Target Ranger. The target ranger is actually a big database that have like a transcriptomic data from GTEx, CCLE, RHS4, NGO, and it also have a proteomic data from human cell outlets like HubMap. So I got my disease data from TCGA, the Cancer Genome Atlas, and then I compared them with that of the target ranger. But I applied a specialized filter, and that was to prioritize only those genes that encode the cell surface membrane proteins. So why is that? It's because these proteins are like most accessible, and they give us ideal drug targets for the small molecules as well as the antibody therapies. Now, I did a data clustering using the UMAP. Here, I clustered 1,000 most variable log transformed genes from the samples. And along with the beauty of this was that these genes also had their mutation data. So here you are visualizing the UMAP, and here each color dot is representing that cluster. And this cluster is actually the representative of those genes. So what is it presenting? So in UMAP, whenever the genes are, or the clusters are distantly placed, it means that there is a significant gene signature. And that is what the UMAP is
Thank you,
showing,
Dr.
that
Rich.
there's after
Okay,
every
time
for
is
every
over.
subtype we have a unique
Sorry,
gene
thank you very
signature.
much. Your
So
time of presentation is over.
just
We can take the
just
questions.
ma'am, can I just conclude the last? It's just 2 slides. It's just this slide.
So I asked the question, what was the result of your study?
So, ma'am, we were able to identify these adephine as a potential drug that can be that is actually a less invasive treatment rather than radical cystectomy. So, and also at the same time, I identified another protein that is the ST14. You can see it on the heat map on the screen as well. This can actually, if we target this ST14, we can also help to overcome the problem of BCG failure.
Okay, thank you. Any other question from the audience?
Okay, thank you, Dr. Rich. So we are at the end of this session, unless someone here wants to still present something. So we are missing one speaker who was not able to join us today, but the rest of the speakers have had the opportunity. We'll conclude this session. Thank you everyone for joining us. The judges will complete their scoring and share it with the secretariat. Okay, thanks again.